Right. Hello, everybody. Welcome to another webinar with the ICO. I'm Sharnel Mandras, for those of you who don't know, the Registrar and Secretary for the ICO. And part of what we do is obviously run webinars like this one as part of CPD, but we also run a postgraduate diploma course in classical osteopathy. Which we'll send some information out about after this. We also do podcasts that we try and get out regularly. We do regular posts and different various courses coming up, like the Breast Matters one that we've got coming up in October that we'll talk to you a little bit more at the end. But for now, let me introduce our speaker for tonight. So we've got Louise Adams joining us, who's a faculty and ICO member, and she's going to be chatting about breast matters, in probably a subject that's often very underexplored by most of us in education and in practice. So it'll be great to be covering that. So when you're ready, Lou, do you want to take it away?
Thanks, Sean. Good evening, everyone. Thank you all for joining on this not so sunny Wednesday evening. So this evening, we're going to be talking about how we can integrate the treatment of the breast into our osteopathic practice. And we're going to explore the breast as this potential missing link in lots of everyday cases that we see. So to do this, I want us to think about the breast in a different way. So coming away from the idea that the breast is just a mammary gland, but thinking about the breast in its mobility and the effects of the breast mobility on the surrounding musculoskeletal areas. So the shoulder, the rib cage, the neck, the thoracic spine. And we see how really the breast and the anatomical connections of the breast can have an impact throughout the whole body, and how by assessing the breast and thinking about it slightly differently, it can open up a new channel when we're looking at things that we see every day in clinic. So just before we start, I just want us all to have a think about, do we routinely assess the breast? Now, when I say this, I don't just mean from a sort of pathological point of view. Are we assessing for lumps and bumps within the breast tissue? But are we considering the health of the breast in our patients? Are we thinking about the mobility, or even asking about nostalgia, about breast pain? Well, I know before I was taught these techniques by Chris Campbell, I didn't really. I was only ever really concerned about the breast in terms of red flags. You know, if there was a history of breast cancer personally or within the family, if the patient had any breast surgery, or if they were having their regular mammograms to check for these things. Of course, if I was treating a breastfeeding woman and if mastitis came up, I would think about the breast then, but never in any of my other patients. So hopefully this evening, you can see why I've changed that, and now I consider the breast in almost most patients. So the breast is the missing piece in lots of common presentations that we see every day in clinic. Yeah, this could be from ongoing sort of recurrent symptoms in the shoulder, the anterior chest tightness, any rib dysfunctions, yeah, ongoing neck complaints. Particularly, I find a lot of sort of thoracic outlet or upper extremity nerve symptoms. Considering the breast in these patients is really, really key to understanding why they're not getting better sometimes. Now, this is not to say that the breast is the cause of all musculoskeletal conditions, but it's one area that I feel is under examined and often can play a vital role in helping patients with their full recovery. So the breast is really part of the fascial system in the body. Yeah, it's part of this fascial continuum that we're working with all day with our patients. The breast is a functional structure. It transmits force, load, tension, and movement. So this is force from the breast, the breast, from breastfeeding or from movement, it's transmitting the force into the breast, but also into the body. So from the breast to the body, but vice versa, from the rest of the body into the breast as well. Force is transmitted through into the breast tissue. Now, I really like this drawing of T. Hall's. Yeah, we can see the polygons of forces, and then we've got sort of arch mechanics. But he's drawn on the front, the breast itself. And I think this is really important, and important just to remember that the breast is part of this fascial continuum within the body. And the breast can tell us so much about a woman's health, about the gynecological system as a whole. Marion E. Clark wrote that the mammary glands are the seat of a great many disorders, many of which are a reflex from the pelvic organs. A reflex from the pelvic organs. Yeah. And since they are part of the sexual system, the gynecologist will be called upon to treat disorders occurring in them. So we have the idea and this understanding that the breast is a reflection of the gynecological system as a whole. Now, when we think through the monthly cycle of a female, we think about that first half of the cycle, the follicular half, we have that slight estrogen dominance, and that causes stimulation of the ducts within the breast. We get an increase in breast tissue volume and vascularity, and increased fluid retention. And then through the second half of the cycle, in that luteal phase, where progesterone raises, we get stimulation of the ducts and the lobules. So it's this change in breast tissue throughout the month that can cause mastalgia, where we're getting an increased volume and fullness. If we have a strain through any of the ligamentous structures that we'll look at a bit later, then that could cause pain, understandably, as any other structure. If there's more swelling or increased fluid retention in the area, we can get more pain. So what Clark's referring to here is that the breast, if someone's having regular mastalgia, secular mastalgia, then it's giving us an indication of what's going on in the whole gynecological system. And I think we can take this further. The gynecological system can give us a really good understanding of a patient's overall health and well-being. Yeah. How well is a patient able to tolerate the hormonal fluctuations? Yeah. We can think of menstruation as a route of elimination from the body. How well is this route working? Yeah. So when we look at breast pain or mastalgia, it's really broken down into 3 different types. We have, as I've just mentioned, cyclomastalgia, breast pain that comes on with the monthly cycle, typically in the second 2 weeks of the month and just before menstruation. And the pain itself is often relieved in the period, but not always. Sorry, just excuse my dog, Charlie. And this pain typically will be in the upper outer quadrant of the breast. And it might be described as a dullness or an ache or a heaviness. Sometimes people get a burning sensation through the breast. And then we can have non-secular mastalgia. So this is sort of caused by any cysts or post-surgery sort of scar tissue in the breast or any injury to the breast. And then we have referred mastalgia, so pain occurring in the breast, which is coming from the shoulder or the ribs the neck, or the heart, or the lungs. So it's reported about 2 in every 3 women will experience breast pain at some point in their life. 20 to 30% of these will resolve, but 60% of these will be recurrent breast pain. So 60% of people will have breast pain recurrently. So then why do we miss the breast? Yeah. Well, in my opinion, we miss the breast because there's generally a lack of training. So then we get uncertainty around assessment of the breast. And it can be concerns around consent when we're treating intimate areas within the body. And also, I think a big one is we focus on the pathology of the breast rather than necessarily the mechanics of the breast. And the mobility of the breast, this is what's important, in my clinical opinion. Yeah. It's essential to consider the mobility and the movement of the breast in relation to the overall body mechanics. And that's what we'll explore this evening. Yeah. So the breast must move. As we move the breast tissue, the breast glides on the chest wall. The breast must be able to move laterally and superiorly. It has to be able to move as the body moves. Remembering that we are this tensegral model. Yeah. As one part of us moves, the whole body moves. And this includes the breast tissue. Thinking as a patient lifts their arms up and we're assessing shoulder movement, does the breast move sort of superiorly and laterally? As someone brings their arms backwards, the breast moves medially and inferiorly. As a patient abducts their arm, the breast moves laterally and superiorly. And as someone adducts their arm, the breast moves more medially. And we might have noticed this on ourselves or not. Women often notice it more with exercise, how the breast moves or they don't move. And with neck movement, as we look down, the breast glides inferiorly and medially. As someone looks up, the breasts are gliding superiorly and laterally. As a patient rotates their head, the breast moves ipsilaterally. And as someone side bends, then the breast moves contralaterally. Both breasts move the same way. And so then this movement is even more exaggerated with thoracic spine movement. As a patient bends forward, the breast again needs to be able to move. It goes inferiorly and medially. As a patient extends and arches the back, the breast moves superior and laterally. As a patient rotates their body, the breasts move ipsilaterally. And as a patient side bends to one side, the breasts move to that contralateral side. And as we breathe in and out, the breasts move as well. As we take a deep breath in, the breasts move superior and laterally. And as we breathe out, they move inferior and medially. So the mobility of the breast can play a role in so many common musculoskeletal conditions that we treat in clinic every day. And it's changing that mindset away from the breast of being just a mammary gland, but being a area of mobility within the body. So now when we're assessing our patients and we're thinking about how well they can move their neck or their mid-back or their shoulder girdle, and they get to a certain point, particularly with sort of arm raising, and they start to get tension or pain, well, maybe that pull is coming from this anterior chest wall. The breast isn't able to glide, so it creates a fascial pull, restricting movement. So, like ongoing rotator cuff issues or thoracic outlet syndrome, subacromial impingements, we'll see how that's all related, through to neck conditions, mid-back Rib conditions, that sort of ongoing costochondritis. And we've got down here lower back conditions, the pelvic mechanics, um, and the lower spine and the relationship with the breast is really fascinating. Now, not only because the breast reflects the gynecological system and therefore what's housed within the small pelvis, but also because of the fascial continuity from the front of the body round into the lower back and the pelvis. And it's not on this picture, but I would go on to say, really we need to be considering the breast health and mobility, even with ankle problems. How is the body moving as a unit? We're all quite familiar with, looking at our common lesion pattern and how the polygons of forces change as we get a change in our baseline. As we have a twist or a torsion or a rotation through the pelvis, we end up with short lateral curves throughout the spine, so that ultimately our eyes and ears are balanced so that we can function. This isn't wrong, this is appropriate. The body is behaving as it should. But if we have a strong torsion through the pelvis, we know we're going to have a torsion through the thorax as well to compensate for that. But the thorax is a 3D structure. It's not just looking at that posterior and what's happening through the ribs, but how is that then reflected through the breast tissue? And vice versa is true as well. If we have a strain in the breast, if we have an injury to the breast, particularly thinking about road traffic accidents, where someone's got that seatbelt across, and if they have a whiplash and they're thrown forwards and backwards, the seatbelt can act as a hinge, but also it's pushing into the breast tissue. So it could cause injury to the breast itself. So then as a result, we will end up with a compensation throughout the body. And we mustn't forget men. Men have breast tissue as well. We'll go on to see the anatomy, the formation of the breast pocket from our campers and our scarpus fascia is the same in men with this fascial continuity. Men have mammary glands present, but they don't develop during puberty because of the high amount of testosterone. Some research says that men do have what we call ligaments of Cooper, which sit between all the mammary glands, and some says they don't. So that would vary patient to patient and probably is dependent on hormone levels to whether those ligaments develop or not. So what I'd like to explore is thinking about the anatomy of the breast, but from this mechanical and more functional aspect in terms of overall mobility, rather than just the mammary glands. So the breast itself, obviously sitting on the anterior chest wall, between the second and the sixth rib. The shape, the contour, the size of the breast, the density will change individual to individual. It will change in an individual's lifetime, and it will change monthly depending on hormonal influences. When we talk about recording tension within the breast, we can often break it into 4 quadrants. So we have the upper outer quadrant, the upper inner quadrant, the lower inner quadrant, and the lower outer quadrant. And typically where we get most myalgia is in this upper outer quadrant. Another way that we can record tension within the breast and think about tension and mobility of the breast is by using the clock face. It just gives us a little bit more specificity on where we're talking about. And say if we have a patient that's had breast surgery, then a typical incision will come down from the center of the clock face down to 6 o'clock and round to 4 and 8 o'clock. So we typically find binding here. Sometimes we have an incision around the top. So then again, when a patient's had breast surgery, we can understand how that scar tissue may be affecting the mobility of the breast and therefore the surrounding tissues. So we've all seen pictures like this. I'm quite familiar with the idea of the breast composition being made up of that adipose tissue, which is filling the space between the functional mammary units. And that's what's really varying the size of the breast. Then we have the mammary glands. They're composed of about 12 to 20 lobes, which contain 20 to 40 lobules, which each contain around 10 to 100 alveoli. And it's the alveoli that these contain the mammary secretory epithelial cells. And then they're connected down these ducts to the areola and the nipple. But the breast is much more than this. So that whole mammary gland, that whole unit is sitting on the chest wall. And it sits on the retromammary space. It's got many names. So it's called the retromammary space, the retromammary bursa, Sassenach's bursa, Sassenach's bag, or the submammary serosa bursa, all names for the same structure. Now, the retromammary bursa aids the mobility of the breast on the chest wall. Now, this is part of what's transmitting the force and the load, the tension, and the movement from the breast into the thoracic wall, and from the thoracic wall into the breast itself. Even though it's called a bursa, it's not like a bursa the rest of our joints. It's not fluid filled in that same way. It's a space between fascial layers. So the retromammary bursa, it binds to the pectoral fascia, sitting on top of the pectoral muscle. And then anteriorly to it, we have Scarpa's fascia. Yeah. And it's the space which allows the movement between the breast and the thoracic wall. So Scarpa's fascia, this is this membranous layer, just here with my arrow, I can show you now, and it helps to form the pocket of the breast. And this Scarpa's fascia is what binds the breast into that pectoral fascia. Yeah. And it's creating the pocket for which the breast sits in, along with Camper's fascia. Yeah, Camper's fascia is this superficial fascia of the breast. Yeah, it's creating the smooth contour of the breast. It's a protective layer, an insulator for the breast. It's supporting the blood vessels, the nerves, and the lymph vessels. So this Camper's fascia and Scarpa's fascia here, they come together to form what we call the circummammary ligament. So the circummammary ligament is also referred to as an anchor point for the breast. And it's the other aspect which really allows the breast to transmit force through into the thorax and out from the thorax into the breast. It aids the mobility of the breast and it helps to transmit the force along with the retromammary space. And in these pictures, it makes it look like it's just at the top and the bottom of the breast. But actually, circummammary ligament is around the whole surface of the breast. Yeah. The breast almost floats on top of this. When you palpate this ligament, it feels like the breast is floating above your hands. So, the Camper's and the Scarpa's fascia, they come up to form the breast pocket. Yeah. This is the fascia from the abdomen. Here we can see the anterior superior iliac spine, yeah, the labia and the pubis. The Camper's fascia and Scarpa's fascia are continuous from the abdominal wall up to the chest, where we're then getting the pocket formed for the breast. We're all quite familiar with the fascial trains within the body. This fascial continuity. Now, fascia changes name depending on the area that it's in, but it is one structure. We can see up there's a posterior chain of fascia, yeah, this anterior chain. But also we have this wrapping, don't we, from posterior to anterior and from anterior to posterior. And we can see how that scapus, and campus fascia are coming up from the abdomen to form this breast pocket, before it then wraps round and encloses latissimus dorsi and becomes the thoracolumbar fascia. And we can see how the breast is part of this fascial system. It's not just stuck on top. So I said that scapus fascia binds into the pectoral fascia. Yeah, a pectoral fascia that binds to the sternum under the clavicle. Yeah, it's coming up and connecting inferiorly with the scapus fascia, that deep abdominal fascia, and then it's coming around to enclose the latissimus dorsi and start to form the axillary fascia. And the breast is anchored to this, and the mobility of the breast is dependent upon this fascia and vice versa. Underneath the pectoral fascia, we have the clavipectoral fascia, which is binding medially from the first two intercostal spaces. It comes out towards the coracoid process. Laterally, it's coming down to enclose subclavius, to enclose pectoral minus, and to form the floor of the axilla. Yeah. This axillary fascia, which is formed from the pectoral and clavipectoral fascia, and forms that dome of the axilla. This is where we have huge vasculature bundles going through into the arm to come round into the chest. Yeah. So now when we're thinking about any neurological changes in the arm, how the breast could have a huge influence on that. And the axillary fascia wraps around, it encloses latissimus dorsi and then becomes this thoracolumbar fascia, which is attaching into the dorsal spine, into the lumbar spine, into QL, and the internal obliques and the abdominal muscles. So we can now get that picture that the breast is this part of this continuity of fascia within the body. Yeah, that scapus fascia that's binding into pectoral fascia. And then the pectoral and the coracoid-clavicular fascia coming to form this axillary fascia, which wraps around and encloses latissimus dorsi as it comes down to form this thoracolumbar fascia. So we can now see how any strain through the pelvis, through the spinal curvature, could be reflected within the breast tissue. So what I'd like to go through is just a few case studies that have really helped with my learning and integration of breast tissue into common presentations. Because not often do we have patients coming in and complaining only of breast pain. On questioning, often we'll find out patients might have breast pain. But I don't think we're highly associated with treating breast pain. So often patients come in with other aches and pains and complaints, and then we're able to also help them with the breast pain. Sorry, excuse me. So my first patient, she's a 64-year-old female, mother of 3. She came into clinic complaining of left-sided periscapular pain, and it was sharp in nature. The symptoms have been building gradually over a few months, and there was no reported onset. Symptoms were made worse by reaching forwards or lifting the arm. Patient had high blood pressure, had a tear to the right ACL, had a history of endometriosis, ovarian cysts, said she had a difficult menopause with lots of hot flushes and mood changes. She had 3 vaginal births, and had mastitis with her first child, and she had surgery for appendicitis in her early 20s. Now, the thing that really stood out for me in this case history for the patient was the history of a gynecological condition or conditions, and having it struggling with the perimenopause, and so maybe not being able to tolerate the hormonal fluctuations as well. Okay. So on examination, the patient had quite a anterior pelvic tilt. There was a lot of fibrosis and hypertonicity through the lumbar spine with a hinging around sort of L2. And there was this global sort of left side bending through the lumbar spine, which then globally went to right side bending through the thoracic spine, which was quite extended. There was full shoulder movement, but pain with flexion and abduction, as the patient had described. But there was no passive or active loss of movement. There was a bilateral shoulder protraction and a bit of tension around the pectorals. And there was a lot of hypertonicity around the left periscapular, with irritation sort of through the ribs, sort of rib 3 down to 6 on that left-hand side. Now, on an examination of the breast, there was almost no glide of the breast, with particularly thoracic movement. With breathing, it was significantly different left breast to right breast. The left really not moving, the right was moving a little bit more with breathing.
That's all good.
And there was a
Thank
lot
you.
of tenderness on the circummammary ligament on the left-hand side from 2 to 9 o'clock on our clock face. And interestingly, the palpation of that reproduced the familiar pain in the periscapular region. So a treatment with this patient, as always, took a whole body approach, but really focusing on the congestion and this kind of fibrotic state of some of the muscles, trying to work on coordinating through the spinal arches to get better movement. And then I did some direct release of the left breast. Interestingly, after 3 appointments, the periscapular pain had completely gone. But often it does, it comes somewhere else, and it was in the anterior chest wall. And sort of a real localized through the ligaments of Cooper on the top part of the breast, which sit between the mammary glands, and through the circummammary ligament. So really the takeaway from this case was that the shoulder wasn't the drive, but the restriction in the breast created a tension within the anterior chest wall, which was affecting the rib mechanics, the shoulder mechanics. Now, this isn't to say that the breast is the cause of the periscapular pain, but the ongoing tension through the breast, which may have been there from mastitis, it might have been there because of the fluctuation changes, because of the gynecological conditions. We don't know, but it was an extra driver for this pain that the patient was experiencing. The next patient I'd like to share is a 48-year-old female. She's a civil servant, desk-based work, and she came into clinic complaining of right-sided hip pain. It seemed to be worse after sitting, like a stiffness as she could stand, but she could stand and walk it off, and there was a sense of a heaviness or tension within the pelvis. But exercise didn't really make it worse. Rest was okay as long as it wasn't sitting. It was one of those presentations which it didn't really add up too much of, okay, was it worse with exercise or rest? But it definitely seemed to be worse just the week before the patient was due on that period. The stiffness really got bad in that week. The patient had also had siccular breast pain for most of her life. Patients' cycles are changing, they're becoming a little bit shorter in bleeding length, but they're still every 28 days. The patient has 2 boys, 15 and 19, 2 vaginal births, and the second she had an episiotomy, and she's had stress incontinence stents. And she had a sarcoma removed from the lateral side of her left shin when she was 35. So on examination of this patient, she was quite a sway back posture. There was a global torsion through the pelvis with the left ilia going posterior and the right anterior. This strain throughout the whole baseline. Interestingly, there was quite a pull and a restriction through this right-hand side, so through the posterior aspect of the pelvic floor, through the obturator muscles, with a tension sort of through the cardinal ligament, which attaches into the cervix of the uterus. And there was a lot of congestion through the pelvis. And there was a lot of fibrotic tension around the insertions of the piriformis. Interestingly, the ligaments of the uterosacral ligament bind into piriformis as well, and there was a pull globally through to this right-hand side, a contracture. There was quite a hypolotic lumbar spine with hinging around the DL and a real extension through the dorsal spine. Her central arch was compacted really around that keystone of D9, and there was practically no shock absorbance in her spine. She had bilateral shoulder protraction. On assessment of the breast, there was tenderness and contracture on the circummammary ligament on the right side from about 3 to 6 o'clock, and the left from 2 to 8 o'clock. And there was a lack of breast movement more on the right side than the left globally, but particularly with thoracic spine movement, there was almost a pull restricting any flexion or extension or sort of lateral movement. So with this patient, it was really interesting with this siccular link and this, and with the history of the stress incontinence and the change in tone that we found on that right-hand side. And we can kind of see how this tension within the piriformis and this change in baseline of the pelvis had caused a strain all the way up through into the axilla, wrapping round into the breast. Or maybe it was the history of the mastitis, who knows, that had caused a pull of the breast, which had caused a strain through the fascia, which had caused a strain through here. Yeah. As often it's a little bit of one and a little bit of the other. Yeah. So you had the episiotomy, we know there's scar tissue on the right-hand side of the pelvic floor. So the real aim with this patient was to begin with just to work on the congestion of the pelvis, to try and get some more fluid flow through the area. So to do that was with treatment, but also re-educating the patient on their ergonomics, how to sit, breathing mechanics, and some pelvic floor exercises. And then through treatment, we worked at releasing the tension patterns sort of throughout the pelvis into the chest, and did some direct work on the breast as well. The hip pain completely resolved within about 6 sessions. The siccular breast pain took a little bit longer, but the patient, I think, now has had 6 months without any breast tenderness. Still seeing the patient, because what we're really working on now is the global mechanics of the spine. Yeah, trying to improve the coordination of those functional arches and to restore her central arch so it doesn't all just come back. Yeah, we can't get rid of the episiotomy scale. You know, that's there. Yeah, we're trying to help her with that. So really from this patient, it highlighted that fascial continuity, yeah, how the breast is part of the fascial system and it's not separate. And equally how the breast health, that kind of siccular breast pain, along with the siccular hip pain, it's kind of one was reflecting the other, as Clark said, the gynecological health. And the final patient is a male. Yeah, let's not forget men. Yeah, men have the same anatomy on their chest walls. So it's a 30-year-old male, he's an ecologist. So sometimes he's out doing surveys, sometimes it is at a desk, so quite a varied job. And he came in complaining of anterior chest pain, just left to the sternum and under the clavicle. And there was a sense of something being present. Patient often also had a sense of brain fog and a presence under or behind his nose. Symptoms have been present for about 8 years. There was no systemic symptoms. The patient had had an MRI and a chest X-ray. Nothing abnormal was detected. The patient has a history of asthma and hay fever, but there was nothing else in his medical history. So interestingly, I treated this patient about 2 years ago before I learned about the breast health. Okay, he came in, he had significant improvement. He had like a little bit of awareness of chest pain, but he was happy and he sort of went away. Sort of, as long as he stretched out, it didn't bother him. About 6 months ago, he returned to clinic, and the chest pain and the sensation behind his nose had gradually been coming back after about the last sort of 3 or 4 months. And stress had always made the symptoms worse. They came on initially when he was at university, and he got married a few weeks ago, so he thought all the stress of all planning the wedding has brought it back. So this time assessing the patient, you know, there was still the irritation in the ribs that I'd found a few years ago. There was this real anterior pelvic posture, quite a neurotic spine. Interestingly, there was an extension lesion around D2 to 4, around that sort of lung field. There was bilateral shoulder protraction and a real thickening of the clavipectoral fascia on the left-hand side. There was a flexion and congestion through the spicothoracic area with this extension through the upper complex, with a lot of congestion through the cranium and the maxillary, frontal, and ethmoid sinuses. The patient was definitely a chest breather, and there was irritation through the costochondral joints from rib 2 to 4 on the left-hand side. But the difference this time is I also assessed the chest and the breast tissue. And there was real irritation on the circummammary ligament from about 9 to 1 o'clock. Yeah, so about that area there. And the chest did not move. The chest wall did not move with shoulder movement, neck movement, or thoracic movement. It was almost the right side moved quite happily. There was a good glide, but the left did not. So this time when treating the patient, also taking in my whole body approach and thinking about decongesting the sinuses and trying to get some movement through the spine, I also did some work directly through the clavipectoral fascia and integrated the movement of the breast tissue into the body. And we had a much faster response. Within 2 months, there was no symptoms. And the real interesting thing of this case for me was that this tension in the anterior chest wall, how it was affecting the lymphatic drainage of the head, especially when we think of this left-hand side and the venous and the lymphatic drainage through there. So his head cleared up much quicker than the chest pain. The patient has a predisposition potentially for congestion of the sinuses with hay fever and asthma. But this ongoing tension here was affecting the ability for it to drain away. So what questions do I ask then? What questions do we need to know when we're considering someone's breast health? So I always ask if someone regularly assesses their breasts, and if so, how often? It's really important when we are assessing for any lumps and bumps on ourselves that we're assessing at the same time of the month, because depending on what phase of our cycle we're in, the breast will feel different. Does the patient suffer from any breast or chest pain? They might not have told you because they might not have known you could help. It's an intimate area. And do they notice any changes through their cycle in their breast? Yeah. Do they get any discomfort when wearing a bra? And if so, what bra are they wearing? If someone's got a very tight bra with underwire, one of these sports bras, it almost acts as a vice around that midpoint. And we can see now we have a vice on that fascia, how it will affect someone's arm movement and their chest movement, their thoracic movement, their neck movement. There's a lovely book called Booby Traps from Maria Kaufman. If you've not read it, as you did a podcast with the ICO as well, and Maria excitingly is going to come and do a lecture for us on the breast course in October. It's a really, really interesting book. Also asking if someone has suffered from mastitis, or if they've ever got any discharge from the nipple. Because it's always important to know the red flags. Yeah. If there's any lumps or thickening in the breast or the armpit, any change in size or feel of the breast, any changes to the skin, puckering, dimpling, any rashes or redness, and any discharge from the nipple. Anything like this should be referred on to check for any pathology. And I think a big point with when we're going to treat an intimate area is that we do, and we must obtain valid consent when we're doing direct treatment on the breast. It's an intimate area. If we're going to ask about breast health and questions, then a patient needs to know why and how the breast connects with the rest of the body so that they know why it could and how it could benefit them from having this treatment. GYOS recommends that if we treat any intimate area of the body, of which they do name the breast, that we should conduct the treatment and assessment at a subsequent appointment so that we can offer a chaperone. Yeah. Often when I'm treating patients, if I'm going to do direct work, it's at treatment 3 or 4. One, because I have to prepare the body to then be able to use these direct techniques, but also to give the patient time and to organise chaperones if we need chaperones, so it doesn't feel like a rushed process. And then the validity of the consent we know doesn't depend on the form, whether it's verbal or written, but GS do suggest getting written consent for an intimate area. Yeah. Myself, I just have a separate consent form called breast consent, and it explains what's going to happen and again reiterates whether they'd like a chaperone. Yeah, a good practice. So when we're assessing the breast, what does that mean? Well, we're going to have a look at the mobility of the breast. If someone's moving different limbs, how does the breast move? How does it glide? Is there symmetry from one side to the other? And is there any tissue drag? If someone lifts their arm or they move their neck, how does that continuity of that fascia move? Can we reproduce any of their symptoms from palpation of the circummammary ligament? Yeah. So treatment of the breast then. We must remember that the breast is a functional unit. It shouldn't be treated in isolation as something separate, but it should be integrated into a whole body approach. I find it can often be a missing link in common musculoskeletal presentations, but it's not the root cause necessarily, so it has to be integrated in. Yeah. In my opinion, the breast should be considered in all patients, as if we would consider all aspects of someone's health in any complaint. Now, this isn't to say that the breast is always, or tension within the breast is always present in common musculoskeletal conditions. It's not always, but it should be considered because it might. And it is part of this fascial continuity within the body. So when we're treating a patient and we're engaging through their pelvis and their lower back, often we're feeling for the movement from the rest of the body and how, as I engage through the baseline or through the lower extremity, what's the response like through the abdomen and through the shoulder girdle and the neck. Yeah. But we don't want to miss the breast as well. Yeah. How does the breast move as I move a patient's leg? Is there a tension? Is there a pull? Similarly, as we come up and we're working through the arm and we're assessing through the shoulder girdle or the rib cage or the neck, considering how does that breast tissue move as I move my lever? Does it change? Now, this is something that we're doing, and we can't not be treating the breast, because if we're treating any of these areas, the breast will be moving and we will be treating it without knowing. Yeah. As we're often treating so much more than we ever know. Yeah. We can't isolate areas of the body, and this goes for the breast as well, in my opinion. So we can use indirect techniques, or we could use more direct techniques on the circummammary ligament to free up that fascial continuity on the ligaments of Cooper. We could think about lymphatic drainage of the breast, but we should always think about the integration through into the thorax, into the shoulder, into the neck, into the whole body. Yeah. Brilliant. So if you'd like to broaden or deepen your understanding of anything that was said tonight, sort of resoluting with patients, then Sandy and myself will be running a course in Peas Lake in October, where we'll go into more of the anatomy and the physiology of the breast, and then go through some direct techniques that we can use on the breast. And Chris Campbell will be joining us as well. And like I say, Maria will be giving a talk on the booby traps book. And these techniques aren't new. Yeah, they've been passed down. Yeah, Chris Campbell kindly taught it to a group of us, and the techniques themselves, it were passed to Chris from John Wernham. You know, they're not new techniques. It's not something new, and I think we're both, Sandy and myself, are very passionate about ensuring that we can broaden how we're using this breast technique and how we can integrate it and keep it within the profession, but also to help people to help patients with things that they're just not aware of. A lot of my patients, when I treat them and I use the breast techniques, they're unaware that I could do it in the first place. And the relief that they get from even just having breast pain is significant. But then when it's underlying to the other aches and pains like hip pain or shoulder pain, yeah, patients really see that connection, and yeah, it's fantastic. So thank you very much for listening, everyone. And if you've got any questions, then please do put them in the chat. Thank you.
Thank you very much. That was so interesting. I think probably like this, like all of us seeing those fascial pictures, we all see them and recognize them, but then when you put them into the context of the breast, you go, of course. It just makes total sense, doesn't it?
It's like anything, it's there in plain sight. And then when you look at it through that new lens,
Yeah. Do we have any questions for Lou? Chris has said, great presentation, Louise. Thank you.
thanks, Chris.
One thing while we're waiting for some questions to come through, I was having a little think about, obviously, when it comes to thinking of females and the breast tissue, surely the bra itself has got to play a big component. And obviously there's that tricky side of when we're assessing that there
Yeah,
must be an element of it blocking some of that movement and limiting the natural movement that we can. How do we kind of get round that as such?
definitely. So it's having that conversation with patients about what you'd like them to wear during the treatment. So even in patients where I don't think the breast is particularly involved, or I'm not concerned about it, I'll ask them to wear loose bras,
Hmm.
because of just the restriction through the thorax. We've all tried to oscillate a spine, and you can just see it's all moving around the bra strap. All those sports bras that hide the spine. When I do direct work, then I always make sure they're not wearing a bra, but they are wearing a cotton t-shirt. So they're
Okay.
pretty, their modesty is completely preserved. They're in a t-shirt, but also it's nice and loose fitting, so it doesn't stop any movement. But I haven't
Hmm.
got the bra. Definitely, if it's an underwired bra, you just can't feel the circummammary ligament because the
Yeah.
wire is there. Um, so always an important question and discussion with patients about what the same as if someone was wearing jeans and they didn't want to take
Yeah.
their jeans off. Yeah,
Yeah. 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 All in context, isn't it? Got
exactly.
another one saying, great presentation. Do you recommend any self-care for patients to support their own breast health?
Yeah, so with all my patients, I think it's really important to be regularly assessing our breasts. I think it's for a patient to know how to assess their breast and at what time of the month they are. So, because sometimes you can get little cysts form or little fibrosis form with age or just during the cycle. So, to be aware of your own breast and confident on how it feels is really important. And same, yeah, with definitely if people have got breast pain, then giving them tips and advice to help at home. Yeah, definitely.
Perfect. And when it comes to your case history with you asking those questions, do you tend to ask everybody those so that they're just part of your normal case history, or is it when they give you some information that perhaps makes you go, oh, I wonder, or is it just part of your normal case history now?
It's part of my normal case history, so part of my gynecological history. For
Hmm.
men, it's slightly different. I just, it kind of rolls into, do you get any shortness of breath? Do you have any chest pain? It can kind of roll into that. But with women, it becomes part of my normal case history.
Mhm.
And when I go into depth about understanding someone's cycle, I always explain why first, and how it can
Yeah.
really demonstrate their overall health and, explain that lots of people do get sickler breast pain or it might not be there all the time, but can you relate to that? And then it opens up the door for people to tell you, definitely.
That's great. Just lots of thank yous in the comments. Any other questions at all? Feel free to pop them in. So kind of moving on from the webinar that we've done today, obviously we've got an in-person course in October that's following on with the same kind of title and things. How is this going to kind of follow on into that? Obviously, it's going to be an in-person one, but is there going to be covering some sort of the proper assessment and treatment and bits and pieces like that? What are you guys going to be covering?
Absolutely. So yeah, in the 2 days, we'll dive much deeper into the anatomy. This was the tip of the iceberg. And then looking at the physiology of the breast through the different stages of life as well. So from puberty all the way through to postmenopause and how we can get those changes. And some of the pathophysiology that we get with breast conditions as well. And then we'll be going through lots of techniques. So I think we've got 5 or 6 technique sessions where we'll be going through the assessment of the breast, direct techniques, but then also how we can integrate this into our whole body approach. And when we would use the direct techniques versus the non-direct techniques as well. And we'll go into consent and consent forms so that afterwards you should feel comfortable to go back to work the next day and to start implementing.
Perfect. And then you've got another question of what kind of percentage of your patients do you find significant breast involvement?
Good question. Stats. Um,
No
I don't
pressure.
like maths. So I think in most my female patients who particularly have given birth, there is an element of tension within the breast that plays a role. Um, in terms of patients that I find it's a real driver and it's like that significant. I really, really want to do that direct work. I feel like it's holding something back. Maybe about 30–40% among my patients. But I treat
Okay,
a lot of
wow.
women's health patients. So again, it's maybe my cohort is different. But then, as one of my cases today was male, it's in my male patients as well, particularly men that play like a lot of cricket. And they're a
Okay.
lot of that bowling action, and that you get that thickening through the clavipectoral fascia that then binds down into the scampus and carpus fascia as well. That seems to be something I've noticed.
I suppose once it's like anything, once you start looking for it, you start seeing it, don't you?
Exactly.
Yeah. Any other comment? Oh, here we go. Thank you, Louise. Was very interesting and something like you said, I've not thought of the importance. As a male practitioner, I would have generally stayed away from it, even thinking of it indirectly. So definitely something to think about now when treating. Thank you for giving me something else to explore.
Yeah. No, I'm glad. Thank you, Jad.
Mm.
Yeah.
Do you think there is a way for our male practitioners to go into this a bit more comfortably? Because I would imagine it's a lot easier for us as females to approach another female and even our male patients about breast health, but that's going to be a seemingly probably tricky route for some of our male practitioner colleagues, isn't it really? Is there any advice you've got for them in handling that?
Definitely. I think like anything when we're talking about intimate areas, sort of male or female, sort of when we have that difference in sex and practitioner and patient, I think it's about understanding why you're asking the questions. Because if you've got that confidence in why you're asking it, then you've got rationale and that you might be able to help them with something sort of through there. And I think definitely as a male practitioner, even just thinking about the indirect techniques and okay, how as I'm moving the arm, you already be feeling how is this all moving, and then how does that move through the rib cage? Well, just don't miss the middle bit. As you're coming around and you're feeling through here, just consider is the breast moving as part of that unit? Yeah. So it doesn't
Yeah.
have to be direct. It's just having that thought process. and just getting used to adding it into your general health questions, I think
Just
is
make it normal.
yeah, easier
Perfect.
said than done. I appreciate.
Yeah,
Yeah.
perfect. Any other comments or questions from anybody or anything that you want to add, Rob, or anything before we finish up? Sandy, that was awesome.
Thank you, Sandy.
But what we'll do is that we'll send you any of the information that's been covered today in an email to everybody just so that you've got it, and we'll send you some information about the course that Louise and Sandy will be running in October in case there's any interest to further your knowledge in this kind of not covered enough subject. So yeah, if there's no other comments or questions, thank you very much for your time, Louise, and that was great. And I think we all learned a lot from that, and your anatomy was fantastic. So yeah, if unless you've got anything else you want to add, then thank you very much for your time.
Thank you everyone for joining, and I hope you have a lovely evening. And hopefully see some people in October.
Thank you. Good night, everybody.